Our next panel for our question and answer session are 3 local psychiatrists, Dr. Richard Idell, Dr. Jeffrey Matthews, and Dr. Greg Poe. If you will each come up and get your microphones, we will start the next round of questions. While they're all getting situated, as a reminder, these bookmarkers have great information. If you have a story to tell, go to the Meadows Mental Health Policy site. Okay to say, write the story of your family, of yourself, write the story and share those stories as they're trying to collect stories. I also grabbed one of these. I'm going to put on the bulletin board at my CPA firm. Take it to your workplace. Let other people in your workplace know that there is help here in Tyler, so that if something happens to them or one of their loved ones, they know we have resources. At this time, we have 3 wonderful doctors from our community who are giving of their Saturday afternoon, and we have a number of questions. The first one I'll start with here is, how can the coordination of care be improved for young adults over the age of 18 between counselors and psychiatrists? Anyone want to take that? Richard, can I pick on you?
Yeah, sure. Let's see if my mic's set here. I think that, the key is communication and frequent follow-up. It sounds overly simple, but I think when we go through the day-to-day, you have a routine that you settle into, and there's a lot of paperwork involved and documentation, and just making sure the flow of your clinic is how it should be. But it really comes down to taking a little bit of time and following up with the specific issues that may be missed during a medication encounter versus an encounter with a therapist. And I think when in doubt, we have to probably make more of an effort on the clinician side to reach out between therapists to psychiatrists and so on.
Okay. This is someone saying that it seems like when there's a suicide in a family or group, it leads to the domino effect, kind of like the 3 students in the class of 300. How do you stop this? Is there such a thing as a generational curse of suicide? So when you're dealing with suicide and families that have had multiple suicides or groups, what are some of the tools that a person could access? How do you help?
Yeah, I think as far as the concept of the generational curse, we know as a general rule in psychiatry that having what we call a first-degree relative with a psychiatric illness puts you at risk yourself. So that's number one. The problem with suicide is that it's, if you think of suicide as a disease, you can't really think of it as one disease. It may be a number of different diseases. And so we're dealing with a phenomenon that is very difficult to predict. It's difficult to prevent, to be honest with you. But there is some evidence that having an immediate relative who died from suicide, especially if that is a violent suicide, jumping off of something, hanging yourself, shooting yourself, that does put an individual at risk. So we do know that much. Maybe the other psychiatrists, a little bit more studied in this area and can kind of clarify the whole contagion effect of suicides. But we do know, as a general rule, an immediate relative with a mental illness puts you at risk, and having an immediate relative who died from suicide does put you at risk.
Okay.
I may add to that.
Okay,
I think, organizations like today and what we're doing here really does help that phenomena that you have heard the speakers right in front of us. Ask people about it, talk about it. When someone's close to them, is it that, I don't think that they've suddenly, now they have this idea, oh yeah, I think that those ideas are probably already there. And then when they see someone do that, they may dwell on it more. I don't know exactly what's going through someone's mind. That's one of the difficult things, is that we never can go back and find out what exactly happened. But I think aware that this is an increased risk, people who are close to them and it's affected, or even people that just knew them and it kind of starts thinking about it. I think asking people about it and really showing that support and that interest and empathy really increases our chance that we're going to be able to address that and stop the epidemic.
And this question is from the other side of that. How can you suggest how to effectively help and support someone who has been snatched from a serious suicide attempt? And this was from someone who says, a suicide survivor family member. What can the family members do? How should they react? What would you suggest if you've had a loved one that's gone through that and survived, has been snatched, as this one said?
Well, I think it's a multifaceted approach that's really necessary after having such a life-threatening event. And we try to address not only the biological side, but the social support and lifestyle factors that may be contributing. Try to ensure safety foremost, and that can involve a hospitalization potentially, or closer follow-up care. But you really want to try to address both sides of it, as it is a stress-related disorder. There's a biological underpinning to it, and by changing both the biology and the stressors that are worsening the illness, then you really can have potentially a significantly improved outcome.
Okay, any other comments on that one?
Yeah, and, one of the big things is being involved in that person's care. And this is, for physicians in general, but for psychiatrists, of course, a very sensitive topic, because sometimes we frankly don't do as well as we should at involving family members, loved ones in patients' care. Sometimes just because of the systems that we work within, we already mentioned fragmentation of care, kind of indirectly earlier, but also that disconnect between what's going on at home with the family and what's going on with the patient when they're sitting here and, in our office talking to us. So sometimes as a family or as a loved one of a person with a mental illness and someone who's maybe attempted suicide or maybe has come close to that, you kind of have to be an advocate, and you have to really sort of be pushy sometimes. With some healthcare delivery systems, you really have to kind of be an advocate for the patient, because sometimes, I hate to admit it, but sometimes that doesn't always happen. Sometimes families are not as involved as they could be. So our part of that is to try to get families involved, or to get people close to patients involved, even if it's not a biologic family. The job of loved ones is also to push for that, so it's kind of a two-way street.
Okay. I have several cards here just kind of on the broader mental illness issue. How do you get, I'll just read them all and then you can just kind of collectively answer. How do you get someone with anxiety to seek help if they're convinced they're doing fine? In what sense is mental illness treatable, cure, coping, compensation? Are there any signs obvious that people display other than sadness when dealing with mental health and suicide thoughts? So just kind of in general, can any of you pick up on any one of those?
I'll take that middle one. Will you read it again?
The middle one on the mental illness treatable?
Yeah.
In what sense is mental illness treatable as far as curing, coping, compensating?
Yeah, I get that question a lot of times, and someone tries to throw off the psychiatrist, who have you cured? And my response is, about the same rate as the internal medicine people cure people with diabetes or high blood pressure. They are very much medically treatable illnesses. We have wonderful medications. We can make lifestyle changes. Their environment affects their diabetes, their high blood pressure. Mental illness is the same way. It's a chronic illness. We have some great treatments, but we don't have a cure yet. Some people may have periods that they're really mental illness for a period of their time, and it may be gone. It may not come back. For instance, if someone has one episode of major depression, after it resolves, there's a 50-50 chance it won't be back. But there's a 50-50 chance it will be back. If they have 2 episodes, there's a 70% chance there's going to be a third one. 3 episodes, there's a 90% chance there's going to be a fourth one. It's a lot like high blood pressure. When I'm younger, I can diet, I can exercise, I can maybe not take medications for a period of time. But if I don't diet, I don't exercise, or as I get older, it creeps back, and I'm going to, at some point, very likely be on blood pressure medications long term. So it's a lot like any other medical condition.
Okay.
And I think you mentioned, getting people into treatment and the difficulties that can be there. And I think, framing the biological side of the illness and the research that's going on now helps with that. People don't have the same struggle at times when they've been diagnosed with cancer or other serious illnesses. It's not seen as a sign of weakness to get treatment for those illnesses. And I think that's part of the stigma that we're trying to combat with events like this, and also just education about the stress that can lead to these biological changes. And there's, with depression in particular, excuse me, there's a growing body about the changes that occur in the brain, a growing body of literature. And in the past we had these pathogens, these bugs that were attacking us all the time. We lived in much different living conditions. And now we have less of that. We have much more sterile conditions, but we have life stress. And it activates the immune system and causes a lot of changes in the brain over time. And I think, as we hone in on the type of changes in the brain that are happening, and people understand that better, there will hopefully be less stigma involved in treatment and understanding that it really is a biological illness to a large degree.
Yeah, and it's important to point out that when you say mental illness, you're talking about such a broad spectrum of things. You have kind of on one end illnesses like schizophrenia that, are very malignant. I mean, many people with schizophrenia don't recover. We treat the illness, we try as best we can to manage their symptoms, try to give the patient the best quality of life that we possibly can. On the other end of the spectrum is kind of the most common mental illness, which is, major depression. And it's very treatable, and many people have full recovery. Some people don't. Some people have recurrent major depression, and we have to deal with that. There was another, I think, and my memory's already failing me here, question about sadness, and that as being kind of a warning sign. One thing that depression is maybe a misnomer in that not everyone who has major depression comes into a psychiatrist's office and says, well, I feel sad all the time. Sometimes it's more manifested as kind of a loss of interest in things. So people who are suicidal, people who are severely depressed, don't always look depressed. It's not always an obvious thing that you're confronted with. Is we kind of have the stereotypical kind of idea of someone who's crying and depressed and sad. It's not always like that. It can be kind of subtle at times. Another sort of interesting thing about suicide is that most people who commit suicide have, we believe, a psychiatric illness, but there may or may not be a direct relationship between how severe their illness is and the likelihood that they'll commit suicide. There were studies way back when, in the 70s, I believe, where they studied families of the Amish, because we can get good pedigrees, and they tend to stay away from drugs and alcohol, so we can study mental illness in these families very well. And there were some families where there was severe bipolar disorder, but not very many suicides. And then there are other families where there were less severe illness, less severe bipolar disorder, or maybe unipolar depression, and there were a lot of suicides. So there's probably more than one thing going on when we're dealing with suicide. We're probably dealing with psychiatric illness, but we're probably dealing with other factors, and it may be dozens of other factors. We don't know. The truth is, it's a very difficult phenomenon to study. So the roundabout answer that I'm kind of giving you is that sadness in and of itself, it can be a warning sign, but is not necessarily the one thing that, we always look for when we're assessing someone for suicide. I mean, sometimes people, one of your speakers even, sort of put up some images here. These are people thinking about suicide. Well, they don't always look sad. They don't always look down in the dumps, The bottom line is, as clinicians, those of you who are clinicians, we have to ask the question, and we have to be fairly direct about the question when we ask about suicide. We have to do a fairly direct assessment of that. I ask every patient who I assess, have you been thinking about killing yourself? It makes them mad sometimes, but, we got to do it. It's part of our job.
Okay.
And on the flip side, sadness is a normal part of life. I mean, we care, if even someone that we know or even watch television, when you see sad things happen to people or tragic things, it's normal to feel sad. I mean, we're interconnected. We care about people. That's kind of what makes us human. So not all sadness is depression. People who are in bereavement may or may not develop depression from that, but a certain part of sadness is the way we interact with our world.
Okay. I want to give a shout out to the Tyler Junior College nursing students who are here today, and this question is specifically our TJC program, our instructors who encouraged them, was that voluntold to be here. We are glad to have you here. The question is, if you could tell RNs something about mental health for the hospital setting, what would it be?
They are often, especially inpatient psychiatry, they're the front line. They're the person who that is going to be able to talk to this individual. They're going to be able, nursing is caring for someone. And when they see someone, they assess someone, having that as something that they recognize and feel comfortable asking about is crucial, because they're the ones who really are in front line. They're the ones who are having that direct contact with people.
Okay, any other comments on that?
Suicide assessment has become a standard of care, by the way, in patients who are admitted to inpatient facilities, not just psychiatric facilities, but anywhere. So you show up in an emergency room somewhere, someone's going to ask you about suicide. You get admitted to a hospital for your diabetes or for appendicitis or whatever, someone's going to ask you about suicide. So you must be versed in doing suicide assessments, suicide risk assessments as a nurse, because it will be expected of you if you are in an inpatient setting.
I would just add that, to try to be aware of any potential implicit bias that may be there, and that's something that's being taught more and more in medical training programs. And by that I mean, if you have a patient that's got, depression, borderline personality disorder, and heart disease, that you try to take an empathic approach, there can be a tendency, I think, to stand back a little bit and be like, whoa, this is going to be a challenging patient in the hospital. But if you take, I think, a more empathic approach and are prepared for any sort of power struggles or issues or conflicts that may occur, you can really potentially help the patient as a whole more.
Okay. Next question, and this really kind of goes back to Michelle's comments earlier, but if a person is unstable and wants to vent, do you think it's wise to put suicide in their head? So when do you ask the question? I guess it's kind of, do you trigger something? Should that keep you from asking the question, what should you do?
Yeah, there's no evidence that asking about suicide precipitates suicide. So that's one of those kind of urban myths that we deal with very early in the game when we train medical students. Asking about suicide is not going to put the idea in someone's head. I mean, people, if anything, asking about it opens the door to dealing with it. So always ask about it. I mean, there's no reason not to, especially in a healthcare setting. Where, just by virtue of being ill, medically ill, you're going to be at increased risk for mental illnesses of all sorts, particularly major depression, anxiety disorders. And so, don't ever be afraid to ask about it.
Okay, excellent. This is from someone who has a son who has had a couple of suicide attempts. He's had depression, an asocial situation. He's been in all types of treatments, on medication, and the family is just saying, what do we do? Where do we go from here? From everything from the medicine to the hospitalization, what can the families do? What hope do they have? What are the resources?
Well, I see children and adolescents, so I'll start off on this one. I think the key is just not giving up and not getting burnt out. There's certainly can be times where it feels like 3 steps forward, 5 steps back, but you try to take a comprehensive approach and see. Perhaps sometimes it's as simple as getting a new set of eyes on the case, having a second opinion. Residential care is always an option, and taking this comprehensive approach where it's not just the psychiatrist, not just the psychologist, but trying to get a treatment team together that's interacting with one another, evaluating lifestyle, evaluating socialization, things like that really impact the course and trajectory of mental illness.
Okay, any other follow-up?
10 to 33% do not completely respond to depressant treatment. That's a third, maybe a fourth. It's pretty common. And I think it really gets the clinician to start thinking about, do they have ADHD? Do they have an anxiety disorder? Are they abusing substances? Have they had a brain injury? Maybe outside of just medications, that, really, people who have depression, mild to moderate depression, medications help, therapy helps, but for mild to moderate depression, there's no clear winner. But every time that we combine them together, people did better than one or the other. So don't just say just medications or just say therapy, but do everything that we can, combine together. ECT, there's some also electroconvulsive therapy. It's the most effective antidepressant we have. So there's lots of things that I think that we say that they're not responded, and really we haven't tried everything.
Try to find other solutions. So when you have a loved one that's suffering from depression, but they can't see it in themselves, how do you help them? When you can see them heading down the same road that led you to try to take your own life, this person is basically shutting out family and those that truly love them. They're constantly in the public eye. So any comment on a situation like that?
It's a very challenging situation, particularly in Texas, a state that values individual autonomy. Unfortunately, if someone does not want to get treatment or recognize an issue, that's their right. But I think what you can try to do is really point out the evidence that they have a problem that's been impactful. And, if they can't see the issue, you try to really present the information in a non-judgmental way and say, these are the things that we're all seeing, we're very concerned about you, and that, there's help out there. And there's nothing wrong with, accepting help. It's not a sign of weakness, it's a sign of just addressing a problem like you would really any other issue, health-wise or other in your life.
Okay, good
And
feedback.
sometimes you have to choose a different gateway to treatment. There's still enough of a stigma with psychiatric problems, psychiatric illness, that I still meet people who wouldn't see a psychiatrist, if it would save their life, and sometimes we do save people's lives. And so sometimes the gateway to treatment is another avenue, sometimes through a primary care provider. Sometimes people will listen to their physician when they won't listen to anyone else. So you have to be creative sometimes. Again, this is, we live in a society where, people have the right not to seek treatment. Sometimes our best efforts do fail, but always think of other avenues and other gateways to getting treatment. So sometimes the primary care provider is the way to go, if anything else.
Any other comments on that one? Okay. This other one is just a broader question. And I'm going to start with Richard because I know a lot of wonderful new things are happening at UT Health Northeast in the area of psychiatric care. But how do you get more psychiatrists in the Tyler area?
Well, I think, what we're doing at UT, I think is certainly the best way to do that, which is to have a residency program and a training program. We're going to have a class of 6 new trainees coming in under Dr. Matthews' leadership, and I think that's going to be a real asset to the community because a lot of times the location where a psychiatrist trains is where they end up a high frequency of the time. And what that really means is for the community, 6 psychiatrists per year, total of 24, when we're at full volume, we'll be seeing patients here. And, the state has been integral in that, and I think really the recognition that this is such a big issue that needs to be addressed has led to the funding for programs like this at the state level. And, having increased awareness and support through programs like this, I think really helps the cause as well.
Okay, and Greg, I know you're with a hospital environment also. Would you like to comment on maybe what you are doing?
Yeah, I second that I think the psychiatry residency is going to be a huge thing for us. I've been here in this community for going on 15 years practicing psychiatry. I can tell you that one of the major problems that we've had from the day I arrived here is recruiting and retaining psychiatrists. What a lot of people don't understand is that, it's not just the uninsured who have trouble getting access to mental health care. You can have a suitcase full of money and good insurance, and you start calling some of the psychiatrists in town, and they can maybe see you in 3 months. Well, if you think about this, if you're in the middle of a major depressive episode, and you're very impaired by that, in 3 months, bad things can happen. You can lose your job because of your job performance being degraded by your illness. People with depression kill themselves. So that's what this whole conference is about. It's about suicide. So I don't have anything to add other than the hopes that the residency program will bring in some services for people. And will also bring in some practitioners into this community. We don't expect all of them to stay. Many of them are going to come from elsewhere and they're going to want to go back to their home cities or whatever. But as a rule, when you have a psychiatry residency in a community, some of those practitioners stay. So I predict that 10 years from now, we're going to be in a better situation when it comes to at least outpatient psychiatry in this community. We're doing pretty good on inpatient services. We don't really have a horrible bed shortage. Where we're maybe failing, I guess, or where we're really having problems is outpatient services. It's long-term care, psychiatric patients, and again, it's not just people who are uninsured. It's everybody.
Okay, and Jeffrey, you want?
I think it's really there's a hope. There's a reason for hope. Psychiatry in the past, there's 200-300 psychiatry residency programs in the country, and a lot of those slots went unfilled. We weren't really training to the capacity that we had, and there's a change in medical students going into psychiatry. Has had a huge increase over the last 2 years across the country. When medical students match, that means they are selected or they are matched with a residency program. Only 7 psychiatry slots across the country went unfilled this year, which has never been happened before. So I think there is an increased interest and an increased number of physicians that really are looking to go into psychiatry as a field. So I think that's exciting for the future.
I'll just say one last thing about that. That I think Tyler is becoming a more and more appealing place to practice. It's been consistently ranked in these Medscape polls as one of the top places in the South to practice medicine. And 2 of my colleagues from Miami came with me. So I think that shows that there is just more and more providers coming out here, and that this, for a number of different factors, is an appealing place to practice.
Excellent. Yeah. Is Fonda in the room? Come up, please. While she's coming, I just want to ask each of you, is there any other message you would like to share today? We've got just a couple of minutes it's got enough time for any one of you to share what your comments would be any message you would want to give this group that has not come in the form of a question.
Well, I want to thank you for coming, and really thank you, the organizers of the event. having this type of exchange, this type of awareness, this type of community support, I think has a huge and a tremendous impact, and not only, but both helping people who have experienced suicide, but the other side is really making people aware and working towards prevent. And I think that this is just having this interest in this level of participation is fantastic.
Excellent.
I just, as I was listening to some of the questions that were put to the speakers earlier, I just wanted to address the issue about, survivor guilt about suicide came up. And what you got to understand, this maybe helps on an intellectual level. I don't think, by any means deals with the guilt feelings that survivors, people who survive a loved one dying from suicide. But, someone asked about warning signs and what could, do you think about what you could have done, whatever. You got to understand that this science is still emerging. And even we as practitioners of mental health, we still don't have very good ways of predicting suicide, and we don't really have very good ways of preventing suicide. We have great new treatments for psychiatric illness that we didn't even have 20 years ago, but suicide rates have, if anything, have increased somewhat over the past generation. And so there's something that we're missing. And it's not really anyone's fault, it's just that the science isn't there yet. So one of my public appeals is in public policy, in your advocacy, right? One of the things that really needs to be pushed in this country is really better research into suicidology and what causes suicide and how can we intervene and how can we prevent it effectively. Because we still, unfortunately, the good news is we have stuff like this where people are getting together and studying this issue, looking at this issue, addressing this issue. The bad news is we're not anywhere close to where we need to be. So in your letters to your congressman, in your public life, right, push for advocacy and push for better attention to this problem that kills a lot of Americans. We saw 40 to 50,000 people annually. So it happens a lot. It kills about as many people as probably tuberculosis. We kind of know what tuberculosis is about. We don't know that much about suicide, and we need to know more. So that's just kind of my soapbox about this topic.
Thank you. And Richard, you started. Do you want to finish it?
Yeah, I agree with what he was saying about research. It's something that we're doing at UT Health Northeast, and it's something that I'm very excited about. I think there are a lot of interesting developments on the horizon. We're focusing on major depression in both preclinical and clinical models, so with people and with cells and animals and things like that. And now we actually do have, surprisingly, a drug that's been shown in certain studies to decrease suicidality acutely, and that's ketamine, which you may know that from it's an animal tranquilizer that's also a club drug, and it's been shown to actually have this anti-suicide effect in certain trials. And it's controversial, no doubt about it, but I think it's opening doors for further exploration of similar chemicals that may have increasingly more clinical use over time. So I think it is an exciting time on the research front, and we're excited to be participating in that at UT Health Northeast.
Thank you, each and every one. We appreciate our psychiatrists being here today. Let's give them a wonderful round of applause. As they're transitioning, I have two public service announcements. First of all, there was a set of Jeep keys with a 360 fitness card and several keys on a key ring. Someone has it. Wonderful. And the person that needs a car to drive home, can you connect? Okay, that was a good success story.
Do you have keys? If you, Jenny, you bring up the keys.
Yeah, okay, so it was going to give you a good exercise opportunity, but we're glad your wheels are back. And then another PSA, your bottle caps. Jacqueline, stand up. Jacqueline is getting bottle caps. Says a 10-year-old gets free chemo for every 1,000 caps. Can I have your caps? If you will leave them on the table or you can take them back that way, that would be wonderful if you're done with them. And then I have one more question that is really directed more toward the broader scope of support groups and what is accessible, and we've talked about that. We have our bookmarker that I've mentioned multiple times. We have resources on the back of it. This question specifically says, I would like to see or know of a support group for 20-year-olds, 20-something generation of mental health in Tyler and the parents of these young adults. So I have asked the executive director for Samaritan Counseling, Fonda, to make a comment on that and just kind of what the general services are, and then once she makes her comment, I'll be back and we'll wrap this up and just conclude another wonderful year.
Thank you for this question, and thank you guys again for being here today. I think this has been announced a couple of times, but for those who are interested in a support group as survivors of suicide, we have a sign-up sheet at the Samaritan Counseling Center table. That being said, if you are interested in other kinds of support groups, just turn it over. Just turn that page over and write out your information and what it is that you're interested in, because we're in the process of forming some groups right now. There are some other valuable resources out there. NAMI Tyler has a table out there, and they have ongoing, really good support groups for people who struggle with mental illness and their family members. So be sure and stop at their table, and there's lots of other provider groups out there, and you can check around and see what people are providing. But Samaritan is actively creating 2 or 3 different support groups right now. So let us know what you're interested in, and we'll get you slotted into those groups. Again, thank you for being here. And thank you, Barbara Bass, for your time today and how well you've done for us.
So our time today is almost over. Our exhibitors will still be here until about 2 o'clock. We have to move out so that our wonderful facility here can be cleaned for their services tomorrow, and we thank Green Acres Baptist Church and Crosswalk each year for allowing us to use these facilities. Let's give them a round of applause. But we've talked about a lot of stories today, and let me tell you a story that I challenge you to continue. We all have circles. We all have networks. The stories you got today, the message you got today, from the personal stories to the professionals who were here, they're stories that need to be told and retold. So go out into the community, your work group, your lunch group, your golf group, your whatever group, your family, your friends. Talk about this conference. Talk about what you learned. Talk about the tools that are available. Talk about the question to ask. Are you thinking about suicide? How to say that question. We were given 2 examples. Talk about having the names of 2 people you would talk to if you were in that situation. Tell about the poetry reading. Tell about the book and the chapter that Laura shared with us. We have been touched today. We have been given tools that we did not have when we walked in the door here. We know how to respond if we think someone is having a problem. We know asking the question is not going to create a suicidal result. So do not fail to ask the question. Ask it anyway. And as you share your story with your circles, hopefully you will get them to the point that they also can tell their stories. Because in some way or other, every one of us is touched by mental illness issues, by family members who are abusing or self-medicating to deal with issues in their life, by friends or family who have committed suicide or who have attempted. This is real life, folks. We get one chance to do it. Make the most of it. Do your part in making a difference, and may God take everything you do and multiply it for His greater glory. And may what you do not only change your lives, but the lives of those around you. God bless you. We hope we see you again next year. To all of our speakers, one more great round of applause. See you in the community. See you next year. Thank you.